Well, thank you all for coming and inviting me. So I'm a great deal of what I have to say today, overall day, will be in the afternoon when I meet with families. I'll answer a lot of the nuts and bolts of how to take care of KAT6A and KAT6B and how to treat that. And so here what I put together are some of the basic studies that we have done focusing on metabolic changes, which is my area of expertise, which is a dying profession, unfortunately. But so I'm just going to go over what we've learned. In the first, I did an abstract. You may have seen in 2018, that was the first 28 patients with KAT6A whom we had studied, and that taught us a great deal. And then we have gone further looking at KAT6B, so it's been difficult to get samples, looking at some other acetylases. There are other histone acetylases, and each acetylase defect has taught us something about KAT6A and vice versa. So we've had sort of an expanding range of therapies to use in an enlarging number of syndromes. So I just want to go over what those are. I'll do, because this is a mixed group in the sense that some of the parents here have been here before or heard my talks, and some are new, and some of the scientists and doctors are new to what I said before. So I'll proceed accordingly. This is just a summary of what I'll try to cover today. The main this is sort of where, how does this work? So I've talked about things up to here previously, and what I'll emphasize in this talk are some recent studies on other histone acetylation defects, such as Rubinstein-Taybi syndrome, which is a very well-known genetic disorder that was not known to have a significant metabolic basis or metabolic effects in it. And again, what we learned in KAT6A has now allowed us to understand what's going on with Rubinstein-Taybi and how to treat that. And it's made a big difference. So just to review, the KAT6A, KAT6B complex is a complex of proteins that have all these different functions. And in particular, in KAT6A, keep trying to point the computer. In KAT6A, from a clinical standpoint, we see abnormalities in, thank you. We see abnormalities in body formation, in craniofacial and heart in particular, but we've also less frequently see effects in hematopoiesis, which is blood tissue, blood organs, I'm saying blood metabolism and cell generation, and that and some of the more striking effects we've had in treatment have been in the blood, in dealing with the blood disorders that we see. But there are this is just one of several different acetylation complexes, and they each function in more or less the same way as shown here for KAT6A. You have a functional group, the HAT center, the histone acyltransferase, which will attach acyl groups, not just acetate, but also propionate and other ones. And where it does this on the genome, on the DNA, is determined by these interactions with the DNA. These are called zinc finger parts of the protein, and this one here, and they attach to certain signals, methylation, as well as acetylation. So the complex runs along, looks for this spot, and then does its work. And we have focused on, from a clinical standpoint, the acetylation, the attention of basically a group of vinegar, acetate to DNA, but just to say that there are other compounds that are used by this and other acetylation complexes. So this is the main conclusion we had in 2018. We had found by serendipity in some cases and by experimentation, clinical experimentation, that carnitine has a particular stimulatory effect. It has a clinical effect in children with KAT6A, sometimes almost immediately. And that when we see that clinically, carnitine, when it acts rapidly, it almost always involves something to do with so-called acylcarnitines, in this case, acetylcarnitine. And acylcarnitine is a general term for acetylcarnitine, propionylcarnitine, butyrylcarnitine, and all of these short-chain fatty acids attached to carnitine that can be converted into a CoA compound, and then that can be used as substrate for acetylation or propionylation. However, what we eventually thought was most likely in KAT6A, that the carnitine effect is that there is, I should just say, I think that's all I had to say here. Also to point out, I think I'll show it in a later slide, that one of the main byproducts of acetyl-CoA once it exits the mitochondrion is to make acetylcholine, which is the main neurotransmitter of the gut. And this relates to, as many of you know, the dysmotility that we see in KAT6A. But it turns out that there's an enzyme both in the mitochondria and in the nucleus. It's the same enzyme that gets translocated in the nucleus. And we treat this disorder. There's a primary defect of pyruvate dehydrogenase that is something like thiamine deficiency and its metabolic effects. And by giving carnitine, a large amount of carnitine, we can activate this enzyme, of which in general only half of it stays active. So we give carnitine and that pushes the activity of it forward or increases the activity. And if there's a deficiency and that should increase the amount of acetyl-CoA. So pyruvate dehydrogenase activity goes up, pyruvate is converted into acetyl-CoA, and that acetyl-CoA can be used by the acyltransferase in DNA modification or in histone modification. And and by giving extra if you have a deficiency of KAT6A, so anyone with true KAT6A deficiency has half the normal amount of this enzyme. And a general principle of enzyme treatment or treating an enzyme defect is give more of the substrate, give more of what the enzyme acts on, and sometimes, or to increase the amount of the enzyme, and sometimes that'll push the biochemistry further. So what we think is going on is by giving carnitine, it increases the amount of acetyl-CoA inside the mitochondrion, and then that allows the residual half normal activity to do more of the work, to take up some of what is not being done by the other gene or the same gene that produce each 50% of the normal enzyme activity. So with 50% enzyme activity, if you can increase the production of acetyl-CoA in the mitochondria, in the nucleus, that should improve function. And this can act very quickly, within hours at times. And we see this in other conditions that are sensitive to carnitine. So that's what we think is going on there. But it's a general principle of metabolic treatment and something that we think about in trying to come up with new treatments for these disorders. And this shows further what we think is going on based on some studies or patients I've treated for decades who have severe intestinal dysmotility. So their gut just does not move. And many children with KAT6A ended up in the hospital with severe colic and pain. Quite a few children have had intussusception, which is a sort of a telescoping of the gut on itself. It's a real surgical emergency like appendicitis. And that's because the gut, when you see that much intussusception, the gut is working against itself, and it pushes its two pieces of it together and it overlaps. So the severe dysmotility, intussusception. But one of the principles of mitochondrial disease is that if one of the main things that mitochondria make is citrate. If the mitochondria cannot make enough citrate, they hold on to whatever they can make, and they send very little out into the cytoplasm. It can be made from acetyl-CoA, but it also can be exported as citrate, and then citrate is turned into acetyl-CoA. It goes in both directions. Anyway, by giving citrate, we increase the amount of acetyl-CoA in the cytoplasm, and that should also increase, should increase the synthesis of acetylcholine. If I go back, so anything we do to increase, so if citrate is deficient, acetylcholine is not enough acetylcholine is made, and the gut doesn't work very well. By giving citrate, we then can increase, I show it here in terms of treating the KAT6A problem, but it works in reverse. If citrate is deficient, we give citrate, and that increases the synthesis of acetylcholine. That's something I've been using in what's called intestinal pseudo-obstruction for 30 years. And it usually works very nicely because there are many mitochondrial problems that have citrate deficiency, and it just turned out that KAT6A is another one. And one of the major biochemical markers we have now in KAT6A is a deficiency. That's a measured level of citrate in the serum is low, and that helps us make the diagnosis. It also helps us recognize what we think are gain of function mutations, where children have a mutation in KAT6A, but it causes an increase in activity, and I'll talk about that a bit later. So I think I've already talked about that. So just to say, there are many histone modifications, and I had discussed this previously, that there's methylation, acetylation, propionylation, and so on. Propionylation has been focused on, that's a 3-carbon unit, so it's like acetate, but one more carbon. Is that it appears to be that these histone sites that have more of a regulatory function have a propionate on the histone instead of an acetate. And so if the KAT6A function is low, it should also interfere with or reduce the amount of propionylation as well. The question clinically is, if we are giving if we are increasing the amount of acetate to help compensate for the deficiency of KAT6A, indirectly we're decreasing perhaps the amount of propionate that can get onto the right spots on the histone. So the question is, what is the balance, and how do you give propionate? This is just to show that among again, here are all the different, they're basically all fatty acids of some sort. It just shows that in this particular site, that propionate and acetate are about equally represented, but propionate, the gray, is throughout many of these sites. But there are some sites that are preferentially propionated. And this is some studies that were done and shown that in both, by doing laboratory studies, I think in animal studies too, they showed that this was that the loss of propionylation was significant from a clinical standpoint or a functional standpoint. So the question is, how do you provide propionate? And there are several different ways of doing that. The normal propionate that is in the body that is available to these enzymes to do the substitution of histones comes from gut metabolism. We all hear about the microbiome, and it's the bacterial action that produces all of these short-chain fatty acids that are absorbed in the bloodstream and processed in the liver and other tissues. But just to say that these short-chain fatty acids, which is what propionate is what is is what is produced by the microbiome acting on fiber. And this is taken up into the bloodstream through the intestinal cells. So that's one source of it. And you could think, well, let's just increase the amount of fiber. The problem there is that that process is already under regulation, that the amount of propionate that is made. And what we're saying here is we need more propionate, and we need enough propionate to balance off the effect of giving extra acetate or acetyl-CoA. So giving a lot of fiber is unlikely to have much of an effect, but it could be explored. The other thing that has been thought about and actually tried in one young volunteer, is triheptanone, which is now used in the treatment of disorders of fatty acid oxidation, children who cannot metabolize dietary fat. And that produces, when it's broken down, it's like a lipid. It's three fatty acids attached to a glycerol, and when heptanoic acid is catabolized, it produces acetic acid plus also one propionic acid, which can then be incorporated into the histone, taken up and get into the nucleus and convert to be added to the histone. It just shows here that triheptanone, a portion of it goes to propionyl-CoA, and a portion goes to acetyl-CoA, which is just turned into energy. And the problem with triheptanone, and I've studied this in several patients with other conditions, they say it's now FDA approved for treatment of certain fatty acid oxidation disorders. It stops working after a year or two. We initially see a good increase in the level of propionyl carnitine, which should be in equilibrium with propionyl-CoA, but it goes away. It goes back down to normal within a year or two, and we don't know exactly why, but it doesn't look like a good long-term therapy. An alternative is the simple amino acid, isoleucine, which I have used clinically for certain problems, for actually quite a diversity of problems, in part to block the transport of tyrosine and phenylalanine to treat certain neurological movement problems. And what's interesting about isoleucine is that I've now used it, I think the longest is probably 15 years. The level of isoleucine and propionyl carnitine that is produced from it stays constant. It doesn't fade the way it does with triheptanone. So this has not been tried in KAT6A, but it's an obvious logical next step. So the idea would be to treat with both carnitine and other way, carnitine, citrate, and isoleucine, and then try to find the best balance for that. That can be done in the laboratory plus clinically. So I mentioned that we think we have 3 patients with gain-of-function mutations. And unlike, this just shows the distribution of KAT6A mutations. Probably most of you have seen this before. And the thing to notice is that you see all these, for example, most of these things have an asterisk, either FS for friendship and an asterisk. Those are mostly what are called truncation mutations. The polypeptide that is being made to make KAT6A stops, and usually it's broken down and becomes just chopped up and the amino acids are recycled. So almost all mutations are truncation mutations or stop mutations. So you have no functional protein. It's a little different when they occur here because the protein can last, the abnormal protein can persist and can throw a wrench into the works, so to speak. But there are 3 patients who have missense mutations. So it's just a single change. Here is some glycine to aspartic acid, at amino acid residue 214. And this one, I can't read it from here. It is from aspartic acid to phenylalanine. And then here is what's called a splice site mutation, which is sort of like a missense mutation in the sense that it doesn't necessarily cause truncation of the protein. It may yield some semi-functional protein. And again, if something persists but it has an abnormal structure, it can actually, in certain special cases, can increase the function of the enzyme or the protein. So what, for example, with this particular one, 214, this is a diagram, a plot of the KAT6A protein, and it's sitting, this region here are the zinc fingers right here that bind to DNA, and they're important for localizing the protein. And for this particular mutation, this just shows where the 214 amino acid glycine formally sits. That's right in the center of the part of the protein that binds to DNA. It localizes. I showed in that diagram how the complex finds its place to work. And you can then therefore hypothesize or imagine that a change in that region can cause that complex to sit on the DNA longer and therefore increase the amount of acetylation. Because these complexes run along the DNA, but they fall off and come back on. It's very much in flux. So one can think that it makes sense that a zinc finger defect, an abnormality in a zinc finger would increase acetylation. And one of the reasons that we think that this is what's going on, at least we think in all three of these children, they have developmental delay. They generally have low asparagine and citrulline levels, where the most characteristic finding in KAT6A are increased levels. Essentially, almost all KAT6A children have low citric acid levels. I have a couple of patients are at the lower limit of normal, but they're almost all below normal. And the gain of function, the citric acid level is normal. So that is the opposite of what you would expect. And it's not that intuitively one would predict that a gain of function would cause the opposite biochemical characteristics, but it fits in a sense, and it's completely different from what we see in loss of function mutations where you lose the whole protein. They do not have intestinal dysmotility, which fits with the citrate levels being normal. And they really only have mildly dysmorphic features, and they have few congenital malformations. And here is a young man from Russia, St. Petersburg, I've been treating, and or just started. I haven't started treatment. I analyzed all the information and concluded that it has a gain of function mutation. And the difficulty in treating a gain of function mutation is to find a way to reduce the acetylation. And that will be coming along, because in treating in the oncology for oncologists, they are looking for ways to inhibit acetylation, which has a role in oncogenic transformation. It can help tumors grow. So the one way has been shown in vitro that it works, that if you reduce the amount of acetylation by KAT6A and KAT6A type proteins, that the tumor stops growing. So it does have a clinical, that's the idea. Yes, they're in development right now. They're not available clinically. And I've tried before in this situation, and a drug company is not going to allow it to be used off-label in the sense that they don't want to experiment with something else and have something go wrong. So we have to wait until these drugs are available. So KAT6A, KAT6B, which we've gotten involved with now, as I know, how many KAT6B are here? Raise your hands. Oh, it's all the same table. Okay. I'll be meeting with KAT6B as a group later. But I've been contacted by about 6 families, and I have metabolic data on just 3, and even that's only partial. And it just had, probably I haven't gone back and checked. All 3 were in this paper by the Arboleda group, and so I suspect that they are the same patients. And just to say, these are all truncation mutations, again, yes. And what's interesting, I was showing on an earlier talk, that these colors don't come up very well, but depending on where the mutation is or where the defect is, you get a different syndrome. So this genitopatellar syndrome is in blue, and that's just in this region. These are gain-of-function mutations. So it's well documented in KAT6B that a gain-of-function mutation can will cause this syndrome, whereas loss-of-function mutation caused this worm salad syndrome here. There is some overlap, but it is interesting to see that, or it is notable that there is this genotype mutation, or genotype-phenotype correlation, as they call it. I think I can make it. So we have 3 patients, which we would assume have different clinical findings, and they do have it list them here. And we have 3 samples showing what the metabolism is, and they're all different. And you can see here, one is the loss of function is here, the intermediate form of genitopatellar syndrome, and then KAT6B, which is not classified as either one. I don't mean to go over this in detail, just to say that they differ. But when I first started looking at KAT6A, they differed from patient to patient to some degree. It was only after looking at the first 20 or so that I was able to see what the fundamental abnormalities were, or what those amino acid abnormalities predicted about the metabolism, and therefore how to treat it. So there are distinct abnormalities here, and which I mentioned here what some of them mean. But the point is, if we can get more of these, I'm hesitant to operate or treat on the basis of just this. I might, but in fact I will. But just say that we get more samples, then it is, then we hopefully will come up with more discrete recommendations for a treatment. As many of you know, unfortunately, most geneticists are not willing or hesitant to do any non-recommended metabolic testing. And you can see it's a catch-22. You have significant findings that you want to try to solidify without going through a whole protocol, which might take 2 years to do, and it might be set up in the wrong way. So these are clinically indicated, so it's trying to get these tests done, but there's still a lot of resistance, partly because most geneticists these days aren't trained in the type of metabolism that I do. So it's a bit of an effort. I think Dr. Esper was, of course, very helpful being a doctor to convince and encourage families in KAT6A to get these studies done. This should show there are some other very distinct abnormalities. For example, a low homocysteine level, we see this in maybe 30–40%, I'm guessing, of children with KAT6A. This is a sign of systemic methionine deficiency. You can only make homocysteine from methionine. And many laboratories don't even give a lower limit because doctors are only looking for high levels. But a level this low means there's something wrong. There's a lack of, there's inadequate methionine, an amino acid. And what has cause lack of, why this has not been recognized before is that the level of methionine, with the normal being 1.0 in blood, is normal, but it can be severely deficient in the tissues. And in fact, giving just methionine in this situation can reverse the bone marrow failure that we see in this disorder and others. So it's important to look for this, and that's one of the most important things now in terms of when I review information on patients. What do we have? What do we need to treat? So this child will I just got this data earlier this week. So he will be going on methionine as part of his treatment. The large red cell size here, even though the homocysteine is not as low, this is also evidence of methionine deficiency. There could be other causes, but it's my experience in this setting that's methionine deficiency as well. It's a very simple thing to treat and benign, and so we just go ahead with doing that without setting up a treatment protocol. I'm unable to set up a treatment protocol now that I'm in private practice. Now, for other acetylases, I was contacted by some geneticists in Europe and in the United States about patients with these acetylase problems or defects in these acetylases. And you can see they have a hat region here, the acyltransferase region, and the same general structure that we see. And it is like the other syndromes, they involve the acetylation and perhaps the acylation of proteins, mostly histones. And this is a type of Rubinstein-Taybi syndrome caused by a mutation in the protein EP300. I was trained as a dysmorphologist, and this is one of my favorite diagnoses. The children generally do well, and it's the kind of diagnosis where they walk in the room and say, it's Rubinstein-Taybi syndrome. You don't have to do any other testing. But now we do have a way to test and show that it is a mutation in this protein or another one called CREBBP. And again, it's similar to the KAT6A, KAT6B complex in that it is you may have either CBP or P300, the acetyltransferases, and all these other proteins that are involved in localizing the DNA, the TATA group, to find the right spot on the DNA for the acetyltransferase to work. So it's very much like the KAT6A group. And this has been very interesting because it's expanded our thinking about acetylation and modification. This is a child with Rubinstein-Taybi syndrome, and these studies were done. These are called acyl-carnitine studies, and these are when a fatty acid is like stearic acid or from olive oil, oleic acid is taken up and turned into energy. It's broken down step by step into shorter and shorter fatty acids. And so these are all the different fatty acids that can be made from a long chain fatty acid. And if you see an accumulation of these intermediate fatty acids, you shouldn't see anything that is in yellow is abnormal. It should all be straight. It should all be in white. So this is a severe abnormality. And yet, if this were a child with a classic fatty acid oxidation defect, he would be in coma, if not dead. And these levels are extraordinarily high. And simply by the fact that he was perfectly normal, walked in the laboratory, had his blood drawn, means that there's something else going on here. And the only logical conclusion is that these acylcarnitines are outside the mitochondria. So what does that mean? And so that And what I have concluded, and they're cytoplasmic, and without going into details, some of them are coming from peroxisomes, not from the mitochondria. But anyway, this enzyme here, acyl-CoA synthase long chain 1, when fatty acids are taken up from the bloodstream, they have to be converted into a carnitine compound themselves, an acyl carnitine, like C18, 18 carbon acyl carnitine, and then it can be taken up into mitochondria and metabolized. And when you have, when they get into the mitochondria, they're broken down into all these different steps. And that's what I was saying, that if there's a block, like at this point, the acyl carnitine levels would be very high and the child would become very sick very quickly and go into coma. And we try to keep these children non-fasting all the time and reduce their fatty acid intake, which helps. So it turns out that when I looked into literature, that that indeed CREBBP, the protein that's involved in Rubinstein-Taybi syndrome, has function outside the mitochondria. It is an acyl-transferase that works on proteins other than histones. So my hypothesis for this syndrome, or for this biochemical abnormality, is that it's the effect on ACLSL1, and that by increasing, and that's under-acetylated. So, of course, I treated this child with citrate, and it helped a lot. But then I also thought, so just to summarize here, these are all the proteins which, or all the conditions in which acetylation is, I feel, clinically important and have shown clinical benefit. So the classical long-chain fatty acid oxidation disorders, which are now screened for by newborn screening, the children with a very long acyl-CoA, with a 3-hydroxy-acyl-CoA dehydrogenase defect, that's a pretty severe disease, and they're always on the edge of going into coma. That is, if they get sick, or if they eat too much fat, or if they fast longer than they should, they get sick very quickly and end up in the hospital. And especially with LCHAD deficiency, it's this one here. They also lose vision and they usually are wheelchair bound by their teenage years. Well, anyway, so I thought about this. So I thought that if I could block in these children, one way, so I can reduce fatty acid intake and reduce the fatty acid level. This is long chain fatty acid. That helps. But if I could block this activation step, that would also help. And it turns out that as a way of signaling, the way the mitochondrion signals to this enzyme, whether it needs it to work or not, is by the level of acetate, the level of acetyl-CoA. If it's high, if the mitochondria is saying, I don't need to oxidize fatty acids anymore, we can shut this enzyme down because we don't need it. So a logical thing is, well, let's give these children, and I've only done it in one so far, let's give them citrate. And it made an enormous difference for a young man who was skinny and relatively weak, although he tried as hard as he could. When he tried to exercise to build up his muscles, to be more like his peers, you know, he's an adolescent in high school and he's terribly embarrassed about his physique. If he tried to exercise, he'd develop a crisis. So I put him on citrate, and you probably can't tell, these are twins. You probably can't tell which one has the serious life-threatening disease, and it's this one here. And that's not the only treatment that I use. He's been very healthy based on other treatments that I've been giving him, but he still was weak and still couldn't build up his muscle. So I started treating him with citrate. And this just shows, so this is his weight gain during growth from puberty. And this is when I added added citrate. He could exercise as long as he wanted without any trouble. And he put on muscle mass. So that picture of him is after that point. This is a few weeks ago. And he just beefed up tremendously, and he can now press more pounds than I can, which isn't saying much. But I mean, he wants to be on the college team, and he can do it now. He has the strength, and he doesn't get in a crisis anymore. So prior to exercise, we give him citrates, and he just goes and goes and has no trouble anymore. So anyway, this I'll go into. Many of the parents know about, but this summarizes what we do for KAT6A, and I've already talked about some of these, but this is what I want to talk about during the sessions. What I gave here is our current understanding of the pathophysiology and what we and what we're looking forward to in trying to improve the treatment of children with these conditions. So I think that's it. Questions?
Okay, thanks, Dr. Kelley. Any questions? I know questions are between now and lunch and our photos. So.
More comment.
I turn this off.
Yeah, excellent presentation. More comment, I guess, maybe a question as well. So you found that PrEP, EP300, the Rubinstein-Taybi syndromes got similar metabolic profiles to the KAT6A-B. I found it interesting because that also happens to be the same condition that it has the strongest DNA methylation profile similarity in our studies when we compare to 60 other syndromes. Yeah. So clearly, and one of the previous questions we had earlier was, are there, correlations by the metabolic cover? It's really interesting to see that. Like, how do you explain that? I'm putting you on a spot because I can't.
Why they have the same?
Yeah, they have similar methylation profiles, very similar methylation profiles, and yet, they're
you have to tell me what genes are involved.
KAT6A versus.
No, I mean, what are those methylation sites? That's what we need to know.
Yeah.
We need to know what genes are being modified, and I can't tell you the ins and outs of the biochemistry of why the methyl groups end up in those sites. But it was, I think it is. No, I agree that this is a way of asking questions about, try to understand more about what these functions are what functions being modified by these genes, and of course. I think you said you looked at the loss of function, gain of function KAT6B, and they're different.
Right. Yeah.
Yeah. So I presume this would be a nice way to confirm that gain of function KAT6A, which just stands to reason that there are going to be missense mutations that are likely to have gain of function, as you see in KAT6B.
Yeah. Really. Like what appears to be the dominant negative gain of function. In other words, right, dominant. Thank you.
Any other questions for Dr. Kelley? And a lot of the sessions will have later today. Thank you. Okay.
Okay.
Great. Connection.